Το πρώτο σοβαρό σύμπτωμα που είχα ήταν ένας πόνος στο στήθος, πάρα πολύ έντονος, όπου νόμιζα ότι έχω πρόβλημα με την καρδιά. Πήγα σε καρδιολόγο και μου είπε δεν έχεις πρόβλημα με την καρδιά, πρέπει να κοιτάξεις τα θέματα του στομαχιού. Απευθύνθηκα σε γαστρεντερολόγο, όπου με μια εξέταση γαστροσκόπησης βρήκα το πρόβλημα της παλλινδρόμησης.
Gerd is a chronic disease of the digestive system. It occurs when stomach acid or stomach content flows back into your esophagus.
Gerd stands for gastroesophageal reflux disease, and it means that abnormal amounts of acid that is normally made in the stomach leaks through the gastroesophageal junction, which is the connection between the esophagus, a swallowing pipe, and the stomach, into the esophagus.
A normal esophagus has peristaltic waves that take the food from the top of the esophagus and squeeze it like toothpaste, essentially by continuous peristaltic waves into the stomach. At the end of the esophagus, right before the food enters the stomach, there is a gatekeeper, a sphincter, a circular muscle that acts as a valve that opens when the food arrives to let the food into the stomach, and then closes to prevent contents from the stomach, most notably acid, from refluxing in the esophagus and causing acid reflux and injury to the esophagus.
And when that happens, then the acid erodes the surface of the esophagus and causes both symptoms as well as damage to the esophagus. And the combination of the symptoms and the damage are called gastroesophageal reflux.
The severity of Gerd depends on the extent of the dysfunction of the sphincter as well as the type and amount of fluid brought up from the stomach.
Το θέμα της ποιότητας της διατροφής και ο τρόπος με τον οποίο τρώμε είναι πάρα πολύ σημαντικό σε σχέση με το που λέμε γαστροοισοφαγική παλλινδρόμηση, που είναι ένα πολύ γενικευμένο πρόβλημα στη σύγχρονη κοινωνία.
So the prevalence is actually increasing worldwide, and it's estimated that anywhere from 20 to 30% of the population has gastroesophageal reflux disease. It's higher in the Western countries, but now we find that it's also increasing in the rest of the world as well.
Gerd is quite common, particularly in Western countries. In the United States, it's estimated to be about 30 to 40 million Americans suffering from the disease. In other countries, in other cultures, it may be less, but in the Western Hemisphere, in Europe and the United States, is probably one of the most common conditions that a gastroenterologist sees every day.
It's pretty equally distributed. I think males may have more, but it's only slightly more. I think it's a disease which impacts both men and women.
It affects men and women to the same degree. However, what it seems to be the case is that women with the disease have more symptoms for the level of damage, and usually they seek medical attention earlier than men, and therefore tend to have less complications of the disease over time.
Symptoms can range from mild to extremely severe. Whichever the case, gastroesophageal reflux disease can considerably diminish a patient's quality of life.
We're dealing with millions and millions of people, and the quality of life is so impaired by reflux disease that it has been compared to suffering from coronary artery disease in many studies. So you can actually expect that the same way that a heart patient can experience chest pain because of a poor circulation of the heart, there is so many more patients who experience similar impairment of their quality of life because of acid reflux.
Ο πόνος όμως ήταν κάτι τελείως ξεχωριστό, ήταν πάρα πολύ έντονος και έμοιαζε πάρα πολύ με αυτό που λένε πόνος εμφράγματος. Είχα δηλαδή ένας πόνος που σου προκαλούσε ένα πανικό.
Well, the two cardinal symptoms of gastroesophageal reflux are heartburn, which means that the person experiences a sense of burning in the chest area, sometimes associated with what we call regurgitation.
So the typical symptoms are a burning sensation behind the breastbone, which is called heartburn, and regurgitation, in which you bring up stuff, acid taste in your mouth, regurgitating food.
Εκτός από τον πόνο που με έκανε να ανησυχήσω και να απευθυνθώ σε γιατρό, είχα διάφορες παλλινδρομήσεις φαγητού μετά από ένα γεύμα, από ένα κακό ποτό ή από ένα βαρύ φαγητό.
Regurgitation means that the person experiences some amount of fluid, usually bitter tasting, acidic tasting, sour tasting, that comes up into the esophagus. And it can come up all the way to the back of the throat and sometimes can go into the lungs and injure the lungs.
That results in obstruction of the passage of food into the stomach and symptoms that are called dysphagia, which means that a feeling of the food getting stuck by the patient, which can result in weight loss, aspiration of food contents into the lungs causing pneumonia and other dire consequences.
So those are the typical symptoms. Once you have these symptoms and they start bothering your daily lifestyle, it impacts your quality of life, that's when you should see your doctor, okay? When you start getting bad symptoms, dysphagia, difficulty swallowing, you start losing weight, you have blood in your stools, that's too late. You shouldn't wait until that happens, but of course if that happens, you should definitely see your doctor.
Obesity and other medical conditions have been associated with acid reflux disease. Left untreated, Gerd may eventually lead to a precancerous condition called Barrett's esophagus.
Σε κάποια στιγμή της ζωής μου είχα πάθει και ισοφαγίτιδα, με αποτέλεσμα ο ισοφάγος να φτάσει σε μια κατάσταση υψηλής φλεγμονής.
Long-standing severe reflux disease can lead to damage of the lining of the esophagus, so it initially leads to esophagitis, which is inflammation of the esophagus, and in some patients it may change the lining.
Patients with chronic inflammation of the esophagus, a small proportion of that change their esophageal lining. The esophagus tends to disguise itself to be better equipped to manage the reflux of gastric contents and the bile. And that mucosal change, we call that Barrett's esophagus.
Talking about the Barrett, of course, the gastroesophageal reflux disease, that is a reason why becoming the Barrett. And then finally, repeated inflammation cause the carcinogenesis, and then finally becomes a cancer.
So Barrett's esophagus means replacement of the lower end of the esophagus squamous epithelium with columnar epithelium. There is controversy whether all patients with severe gastroesophageal reflux go into Barrett's, or Barrett's is a separate de novo incidence that's occurring. This has not been confirmed, but probably Barrett's occurs de novo because there seems to be a genetic predisposition, especially in the white race, for Barrett's compared to Asian population where the incidence of Barrett's is low.
What we have seen is obesity is a major factor. As the world's population is becoming more obese, I think that's impacting the prevalence of gastroesophageal reflux disease.
The leading element that predisposes both to reflux as well as to Barrett's esophagus is obesity. And obesity, as you know, is a phenomenon that is increasingly recognized as a public health issue in the Western world. It is happening in Asia as well, but more so in the West so far.
If you look at patients now, especially in the Western countries, there's a correlation between obesity, Barrett's esophagus, and adenocarcinoma.
In obese patients, stepping back, I mean, gastroesophageal reflux disease, the main problem is at the area of the gastroesophageal junction, okay? So the lower esophageal sphincter compliance and the G junction compliance is impacted by obesity. So these patients can get disruption of the gastroesophageal junction, can lead to the presence of hernias, and that can promote gastroesophageal reflux disease.
And that is the number one risk to the development or the continuation and perpetuation of gastroesophageal reflux, as well as the induction of complications such as Barrett's esophagus and esophageal cancer.
There are many factors associated with the development of GERD. Dysfunctions in the lower esophagus sphincter or a hiatal hernia are often considered as cause.
The predominant issue is what we eat and what we do with our lives, and acid is playing a significant role, of course, because we tend to overeat and we tend to bring the acid to the wrong place, which is the esophagus.
Σε συνθήκες έντασης επαγγελματικής, που σε κάνει να τρως σε ακατάσχετες ώρες οτιδήποτε βρεις μπροστά σου, τότε τα πράγματα χειροτερεύανε. Σε καταστάσεις ηρεμίας, όπου μπορείς να ελέγξεις την ποιότητα της τροφής και το ρυθμό με τον οποίο θα τρως, η παλλινδρόμηση εξαφανιζότανε.
I think a lot of it is from lifestyle and habits, and some of them are environmental. Eating fatty foods, eating late at night, eating foods which reduce your lower esophageal sphincter pressure, such as coffee, alcohol, mint, things like that, they can all precipitate symptoms of gastroesophageal reflux disease.
There are some genetic elements, but they do not really represent the majority of the cases at this point. Obviously, if a particular family has reflux or esophageal cancer or Barrett's esophagus, you may actually see that in the offsprings, but it's not the predominant issue.
I don't think stress is a causative factor. It will relate to the way patients appreciate symptoms, and it may trigger an endoscopy in an earlier stage. Especially if patients with a Barrett's esophagus, they have an underlying reflux disease that may trigger their indication for endoscopy.
There are some unfortunate individuals who, even if their weight is appropriate and they're very thin and they eat well, they do suffer from reflux. Typically that population has a hiatal hernia.
Ήμουνα καπνιστής και ήταν ένας από τους επιβαρυντικούς παράγοντες αυτός. Εγώ κόψα το τσιγάρο έτσι κι αλλιώς, από μόνος μου περίπου τότε, και αυτό ίσως έπαιξε και ένα ρόλο στον έλεγχο της παλλινδρόμησης.
Hiatal hernia means that a portion of the stomach comes up into the chest through the diaphragm, which is a big muscle of breathing. And so this portion of stomach that now sits in the chest tends to allow the acid that is normally made in the hernia pouch to leak into the esophagus. So if you have a hiatal hernia, you are predisposed to more acid reflux and more complications from reflux, such as Barrett's esophagus or esophageal cancer.
Diagnosis for GERD is possible even at an early stage. A clinical image is made possible using standard as well as sophisticated methods and techniques.
We have many ways of diagnosing gastroesophageal reflux. We have ways to look into the presence or not of acid reflux in the esophagus by measuring the pH over a period of time. We have methods to look at what damage the acid has done to the esophagus, and the key method there is something that we call an endoscopy, in which a flexible instrument is introduced through the mouth and allows us to look inside on a TV screen, if you will, of how the tissue looks.
If you perform endoscopy in reflux patients, the majority of them will have a normal endoscopy, up to 60 to 70%. 20 to 30% may have inflammation or esophagitis, okay? So that's called erosive esophagitis or reflux esophagitis, and anywhere from 5 to 10% may have Barrett's esophagus.
If we find some esophagitis or something chronic change of the esophageal mucosa, we have to pay attention if there is cancer.
Screening then should either be done by trying to find patient factors. How do we identify the patient that may have a Barrett's, that may need screening? or increasing the number of endoscopies that we do, or finding a tool that we can use without doing an endoscopy. So swallowing a capsule, swallowing a sponge on a string that you can remove and that you can then investigate.
And then if, for example, the patient has the Barrett esophagus, so we have to be very careful to check the high-grade dysplasia on a Barrett.
And we have other fancier tools to diagnose reflux and to determine its severity. And those tools are much more sophisticated, but they allow us to measure, for example, the level of pressure that is in the valve that separates the esophagus from the stomach.
Ο γιατρός, κάνοντας την εξέταση της γαστροσκόπησης, δηλαδή ενδοσκοπικά είδε όλο το στομάχι και τον ισοφάγο, είδε έναν ερεθισμό στον ισοφάγο, ο οποίος αυτός ο ερεθισμός οφειλόταν προφανώς στο σύνδρομο της Παλλινδρόμησης.
So the tools are available widely, are relatively inexpensive, and they are, I would say, simple for the patient and not necessarily requiring a hospitalization.
Standard treatment for GERD includes a combination of acid-reducing medicine and lifestyle changes, like avoiding large meals or eating before going to bed.
If you have symptoms of heartburn, regurgitation, you have a very high likelihood of having GERD. So it's a symptom-driven disease, and the physician should be aware of that. So they're not doing 100 tests to make the diagnosis. So you should be typically seeing what the patients are telling you, making the diagnosis, and appropriately treating the patients.
Αυτό που μου συνέστησε ο γαστρεντερολόγος ήταν η φαρμακευτική αγωγή και διάφορα άλλα σχετικά με το θέμα του πώς τρως, πότε εξαπλώνεις, πότε κοιμάσαι μετά το φαγητό κλπ.
The physician usually counsels the patient about what to eat, what to avoid eating, how to do this, in other words, avoiding late meals, avoiding lying down in bed after a heavy meal.
Lifestyle changes are important. If you know the triggering foods, for some patients, every time they drink a lot of alcohol, they get these symptoms. If they have fatty food like pizza, they can get these symptoms. So you just have to prevent, not eat those, or eat in moderation, and you can prevent those things. Not eating late at night, sleeping with your head end up. Those are some simple things, lifestyle changes that you can do.
Προσπαθώ λοιπόν και αντιμετωπίζω την παλλινδρόμηση συντηρητικά, προσέχοντας αυτά τα τρία, δηλαδή όχι ανθρακούχα ποτά, όχι προϊόντα που περιέχουν στοιχεία που φουσκώνουν το προϊόν, όπως είναι οι ζύμες και τα διάφορα μπισκότα και κούκκις κλπ. Και όχι κατάκληση μετά από ένα βραδινό φαγητό, τουλάχιστον μετά από 2-3 ώρες.
Physician can counsel the patient about lifestyle modifications that would allow the patient to maintain a healthy weight and a healthy diet, not to gain weight, not to allow obesity to come into play. All of that is obviously a much necessary package, if you will, when the physician meets the patient.
A decrease in obesity would be very important, so the reflux doesn't occur and Barrett's has decreased. It has also been shown that healthy lifestyles like, for example, stop smoking, moderate alcohol, cut down on the alcohol, and high vegetable diet.
This counseling is not as effective in the modern era. Because of that, we end up seeing more and more people who have failed the diet and lifestyle modification approach, and they quickly go to the pharmacy and they get a relatively inexpensive medication.
Then of course you have medications such as the general categories H2 blockers such as ranitidine, cimetidine, things like that, and then you have the other class of more potent acid suppression called proton pump inhibitors, and that's like omeprazole and pantoprazole, esomeprazole, lansoprazole, medications like that, and those are proton pump inhibitors which can also treat reflux.
By using a medication that what it does, it suppresses the acidity in the stomach, It suppresses that acidity from coming to the esophagus to the same degree that it used to before, and therefore we end up, by using the medications, to continue perpetuating the problem because we have the medications to cover things from happening.
Μπορώ να αντιμετωπίσω την παλλινδρόμηση συντηρητικά και μόνο σε έκτακτες περιπτώσεις, να χρειαστεί να πάρω κάποιο χάπι για 1 ή 2 μέρες, αναλόγως αν έχω κάνει ένα γεύμα πάρα πολύ βαρύ και που έχω επιβαρύνει κάπως το στομάχι μου περισσότερο.
Endoscopic therapies have been beneficial in many patients with reflux who basically get better and they don't have symptoms anymore or damage anymore. And we do that by placing an endoscope through the mouth into the esophagus and working over a period of, let's say, half an hour to 45 minutes to modify that valvular function.
Surgical interventions are considered when the damage in the lower sphincter is so extended that its strengthening is no longer possible with drugs.
There are actually several ways of dealing with the reflux problem using surgical techniques. The most established one is a procedure that's called laparoscopic fundoplication, in which the surgeon reconfigures the valve again.
So fundoplication is the surgical option, which is surgically repairing the hernia. And in a subset of patients, they may require that. And these are patients who have large hiatus hernias. These are patients who have a lot of regurgitation. That subset may require surgery at the end. But I think the majority can be taken care of by lifestyle changes and medical therapy.
There's another technology that has been recently introduced that it's much easier, but again, it's a surgical technology. Again, through a laparoscopic approach, a small little ring of magnets is placed at the level of the valve of the esophagus with the stomach. That system, called the LINX system.
There are also other possibilities of implanting things by using this tunnel technique, such as pacemakers that improve motility of the esophagus or stomach, or even inserting stem cells into the muscle of these patients that may even allow regeneration of nerves and activity of the muscle.
Another technique that is being developed is something that we call lower esophageal sphincter neurostimulation.
Even though every patient with Gerd is unique, compliance with a whole new diet is essential for the diminishing of Gerd's effects.
In terms of prevention, the only thing we can do is to make sure that we eat well, we eat a balanced and limited Mediterranean diet, which is probably the best, and avoid eating late and going to bed early after a meal.
We start leading healthy lifestyles, we reduce the incidence of obesity in the world, and we can probably prevent a lot of these symptoms from happening. So I think that will make for healthy living and for reducing reflux disease in the world.
All of these approaches should cover most of the patients who have the propensity to have reflux disease, and they do cover also most patients who have reflux disease because they help them manage the disease better.
Ζώντας με την παλλινδρόμηση παραπάνω από 20 χρόνια, έχω καταλάβει ότι προσέχοντας τη διατροφή σε αυτούς τους τομείς που εγώ έχω την εμπειρία, μπορείς να το αντιμετωπίσεις και να το διαχειριστείς.